Today we're going to be talking about the causes and prevention of poor embryo quality in IVF. We'll be looking at the underlying factors and exploring preventative strategies aimed at optimizing outcomes. I'm thrilled to have famed fertility doctor, Dr. Geoffrey Sher, on today's show again. Welcome, Dr. Sher. Thank you for joining us.
Thank you.
Welcome to the Egg Whisperer Show. The title of today's show is Causes and Prevention of Poor Embryo Quality with IVF, Understanding the Underlying Factors and Exploring Preventive Strategies Aimed at Optimizing Outcomes. Dr. Sher is founder of Sher Fertility Solutions and is an internationally renowned expert in the field of assisted reproductive technology. He's been influential in the births of more than 17,000 IVF babies, and over the last 36 years, he's helped fashion the field of ART. After training with the fathers of IVF, Dr. Steptoe and Edwards, he established the third IVF program and the first private IVF center in the United States in 1982. He's authored over 200 scientific articles and abstracts and has authored several books, including his most recent, From In Vitro Fertilization to Family, written with his partner, Dr. Drew Tortoriello. Dr. Sher, welcome, and let's dive into this topic. My first question is, what are the most common factors contributing to poor embryo quality in IVF?
I've done quite a few of these podcasts with you, but this one that we're doing today is extremely important because 80% of success in IVF and 80% of repeated miscarriages or sporadic miscarriages all are based upon there being an embryo incompetency. And the first thing to say is that I'm hopeful that those people that listen to this podcast will come away with an understanding perhaps of why their IVF that they've done may not have worked. Let's start by saying that the embryo competency is the most important determinant of successful implantation. And competency of the embryo, although not exclusively, is largely a function of the chromosomal integrity of the embryo. What's more important, and for everyone to understand, is that it stems primarily from the egg. Although the sperm does play a role, especially if the man is severely infertile and got major problems, the egg has got the ability of discerning between the sperm it wants and the sperm it doesn't. And if there are enough good sperm around, it'll always find the right one to bring in. So it's usually 80% of the problem lies with the egg. And it's the factors that impact, therefore, on the integrity, chromosomally, and genetically of the egg that will determine success or failure. What can we do to give those eggs the best chance, if they're normal ones, to come out being euploid? Because euploid eggs will make euploid embryos. Chromosomally normal eggs will make chromosomally normal embryos. And that's where we need to focus. What are the variables that affect egg competency and quality? Embryo quality, oftentimes you hear people say, is the laboratory that important? Of course, you've got to have a good lab. But most of the time when there's a problem with embryo competency, it's not the lab's fault. Most good labs and even average labs can do the process of fertilization and ICSI and biopsies pretty well. So the important thing is to understand what the variables are that affect egg quality. 3 factors stand out as being responsible for the vast majority of factors that affect the quality of the egg. The first, of course, is the woman's age, because the older a woman becomes, the more those eggs that are in her ovaries that have been there all her life are going to be exhausted eventually and end up with her being in the menopause, undergo wear and tear. And the wear and tear impacts on the ability of the chromosomes in that egg when it goes through its final stage of development or maturation called meiosis, which is the 40 hours before the egg is extruded through ovulation or extracted. In that time, the egg goes through a very important process which prepares the chromosomes for orderly fertilization. The second factor is ovarian reserve. That means how many eggs are left in the ovaries. The woman's born with all the eggs she's ever going to have, and the amount of eggs left behind at the end of the day when she tries to have a baby is the reserve in her ovaries. That is something we used to measure by measuring things like FSH, LH, inhibin B, and a number, and even antral follicle counts. But today, it's really come down to measuring the anti-Mullerian hormone produced by the ovary, which declines as the number of eggs left in the ovarian repository drops. And so an AMH of more than 2 is optimal. It doesn't mean that an AMH of under 2 is always suboptimal, because older women will have a lower AMH, and that's physiological. But in terms of optimizing the potential for successful fertilization, we'd like to see an AMH over 2. If it's under 1.5, there is a problem evolving. And when it falls below 1, the woman's got severely diminished ovarian reserve, which we call DOR. If the AMH falls, it's not just that there are fewer eggs left and fewer will be retrievable, which in of itself is an important consideration. Because if a woman's older and she's also got diminished reserve, the age will diminish the competency of the egg, and access to the number of eggs will compromise how many are available to be fertilized. So ovarian reserve is important in that regard. But there's another very important factor that goes along with diminished ovarian reserve that is often inadequately appreciated. That factor happens to be that women with diminished ovarian reserve have usually got increased production of the pituitary hormone LH. And as a woman gets older, the level doesn't even have to go up. It's the biological activity that increases with age as well. So women who've got diminished ovarian reserve have not only got fewer eggs, but they're overproducing LH. LH causes the ovary and the connective tissue in the ovary to produce the building block hormone testosterone and androstenedione, primarily the former. If there is too much testosterone, now it gets into the fluid of the follicle, and it causes in the egg, in the granulosa cells that line the follicles, something we call premature luteinization. And these cells stop producing estrogen. Now they start luteinizing, the follicle stops growing, the egg doesn't develop, and the rising level of estrogen plateaus and then falls prematurely. All of this is indicative of overexposure to LH-induced testosterone, which impacts the follicle and what often goes along with that. Also, the luteinization causes progesterone to go up, and you see that rising as well prematurely. That's why doctors look for progesterone levels before they trigger the woman to see it's not too high. They know if it's too high, there's a problem, and that problem goes back to premature luteinization. So the secret of getting to good eggs or protecting the eggs in their development is to use a protocol of ovarian stimulation that gives exposure to some LH-induced testosterone, but not too much, and at the same time allows for adequate follicle growth and number. That means we've got to individualize the protocols of stimulation, and that's the third factor. The first factor is age, the second factor is diminishing ovarian reserve, and the third one is the ovarian hormonal environment, which is really the only one of those three things that we as physicians can influence. We can't make the woman younger. We can't, no matter what you read about, rejuvenate the eggs with injections of PRP and things. We may think we can, but it's not that successful.
I would argue with you that I can. I mean, in the beginning, I thought I was very skeptical, but I have patients. I have a 45-year-old. She did 5 cycles of IVF, not even a single blast, and she got blast and a euploid. She hasn't transferred it yet, where she wants to bank another embryo. I mean, I have situations where patients are 43, 3 IVF cycles, not a single euploid. They do ovarian PRP with me, and I get them 2 euploids. Like,
I'm not going to argue with success.
mind-blowing stuff, but it certainly doesn't help everybody.
I
Certainly.
would certainly be interested in hearing more about that, but let's put it this way. I remain skeptical about the value. I think uterine PRP may have a place, but ovarian PRP, I'm not sure you can make a woman produce more eggs, and the only way the AMH goes up is if she makes more primordial follicles. I don't see that being a factor.
So I have a patient right now, over 40. Her AMH was 0.12, follicle count less than 3. I did ovarian rejuvenation on her and put her on rapamycin. Her AMH right now is 1.3. She has at least 12 follicles, and we're heading into an egg retrieval right now.
Obviously, I have to broaden my own
Yeah.
horizons and listen to you a little bit closer.
It's still all very experimental. The jury's still out. We don't have live births, so I don't want everyone rushing to do these treatments. But I'm hoping,
Because
yeah,
my partner, Dr. Torriello,
yeah,
believes in it like you
yeah,
do.
yeah,
I remain skeptical, but I'm
yeah.
open to be convinced.
Yeah, I love it. So let's talk about the preventive measures that, let's say, I don't like calling women older because I think a woman who's 40, she's a hell of a lot younger than I am. I don't consider her older. So I'm going to say when her mitochondria are older, what kind of measures can a woman who has older mitochondria take to improve embryo quality?
Well, first and foremost, we need to understand there are certain things that a woman can be exposed to inadvertently or knowingly that can adversely affect egg quality. There are pollutants that can have an effect, as you know. The big one is bisphenol A, which is found in many products, including plastics and metal can liners, reusable food containers. There's some data that suggests that overexposure to bisphenol A compounds can lead and compromise egg quality. And of course, these things can be absorbed through inhalation, ingestion, or skin absorption. There are also organochlorine compounds, chlorinated pesticides, and biphenols and dioxins, which the woman can be exposed to. There's some evidence that eggs that come from chickens that feed around certain waste scrap yards and waste yards and burning dump sites and medical waste incinerators contain higher concentrations of organochlorine compounds. And then there are air pollutants, which are gaseous pollutants, organic compounds, heavy metals, and particulate matter. We haven't got them well defined. A lot of this is controversial, but there is some evidence that this can impact on egg quality.
So, Jeff, so basically you're saying we all have to call poison control. I'm kidding. I mean, it sounds like we're being poisoned, and it's just crazy. I mean, I
I
feel like,
truly believe that is the case. I think in the foods we eat today, many more of these compounds are available, and we have to be careful about that. There's some evidence that these air pollutants that come from traffic emissions and industrial processes and urban activities can disrupt hormonal balance in the ovaries, decrease ovarian reserve maybe in some way, and lower the antral follicle count. So we've got to be aware of what we ingest and what we're exposed to and be cognizant and probably stay as much as we can with natural foods. There are dietary things that we can do that are helpful. Perhaps we need more whole grains and vegetables and fruits and legumes and nuts, seeds, fish may be helpful. Mediterranean diets seem to be better than the ones we indulge in here in the Western environment, which
mhm,
could be detrimental to egg quality. So I think that's important. And then, of course, there are certain supplements that are believed to have a positive effect. And we may have a difference of opinion again here, and that's healthy and that's good. But things like folic acid, coenzyme Q10, inositol, melatonin, vitamin D3, maybe even fish oil and things like that, maybe vitamin E, zinc, and certain B vitamins may be helpful as being antioxidants. I'm not a believer, and this is where we may differ, in the use of DHEA.
I'm right there with you. I say DHEA is terrible for eggs.
I think it's the worst thing you can do, especially if you've got diminished ovarian reserve, because as I alluded to earlier on, you don't want too much testosterone around, which is bad for egg quality and follicle growth. And DHEA is a precursor and it converts to testosterone and other androgens. I avoid it like the plague. I'll tell you what made me do it. We started off doing some of the research on DHEA, and there was a lot of interest. And then I did, and it's not a published study, but we took 6 women who were voluntarily willing to go in onto DHEA, and we did monthly evaluations of their ovarian reserve. And we found that there is a deterioration in women that have diminished reserve already if you go onto DHEA. So I've withheld DHEA completely from my patients. I advise them against it.
I think that's really important for people to hear because so many patients are told to take DHEA by their acupuncturist, by their friends. They've read a book that tells them to take it. And especially for women who have endometriosis, it's terrible.
It's especially bad for women who've got diminished reserve or who are older and already are plagued by an overexposure to ovarian androgens. And so that's the one thing. But a far bigger problem than that is using protocols in women that increase the testosterone in the follicle and increase exposure and cause premature luteinization. I cannot tell you how many patients I see that come to me with very poor histories of response, and we tailor the protocol to limit exposure to LH-induced testosterone, and they do far better. And I have a woman who lives very nearby you, and I'll introduce you to her sometime. Her child is in the Air Force. She's a jet pilot.
Wow.
She came to me at the age of 47.
Yeah.
And she had done 17 failed IVFs and wanted to do more. I was very much against it. I tried to persuade her that this is not the time to play tricks. You need to go and do egg donation. She refused. And I did in San Francisco 6 cycles of IVF. On the 6th cycle, I got 2 euploid embryos. She gave birth to a child after the transfer of one of those. And he has my name and I'm his godfather.
Oh, I love that.
But bottom line is older women can have babies. They just have to understand that no matter what we do, the chance that any given egg at any given time being competent and chromosomally normal is very much reduced and impacted on by the biological clock. And there's nothing you can do about it short of perhaps what you say, do ovarian PRP, but I need to be convinced.
I, just like you, see a lot of patients who come to me for second, third opinion consults. And I ask patients, like, what was the quality of your embryos? And they say, oh, they didn't tell me. And they say it doesn't matter. So now I want to talk about the sperm component because we know every embryo is an egg and a sperm cell. And you mentioned that 80% of embryo quality is egg driven, but there's still that 20% that we should talk about. What role does the quality of sperm play in embryo development? And what can be done to improve sperm quality?
Well, first of all, we know very little about how to improve sperm quality. The best we can do is try to select the best sperm by using various procedures in the lab, Pixie and other things, which helps us identify the sperm that looks best. Problem is, there's nothing you can do about sperm that are abnormal once they're abnormal. You can't rejuvenate them, you can't improve them and then use them. You can give the man certain antioxidants and sperm enhancement preparations that will potentially improve the sperm environment. And the one I use, and there are many, is not available through the drugstores. It's called Proceptin, Proceptin, and I send my people to the website proceptin.com. They can buy it off the website. It is the best male fertility antioxidant blend that I've come across. There are others as well, but in my opinion, that's the best one. I also tell men the same things I mentioned about women, but the sperm life cycle is 3 months. So the man gets off the hook pretty easily. All he has to do is be clean for more than 3 months and his sperm will restore itself in many cases. But I try to tell my male patients to avoid too much alcohol, too much exposure to heavy metals, and to be careful about smoking. Those that are overweight, I advise them to try to get into shape. And I encourage them to eat well, rest, and try to avoid stress because stress does affect male factor. There are many things that can compromise sperm production, and there are certain conditions that the man can get that are deleterious. There can be a collection of varicose veins in the testicles called varicocele. That can cause problems by heating up the testicles and reducing the normal process of spermatogenesis or sperm production. And that can be treated by obliterating the spermatic vein. I usually advise my male patients who are eligible and are candidates for that, I advise them to have ablation of the spermatic vein rather than surgery. Because when you do surgery, like the urologists love to do, to tie off the spermatic vein, they don't take into account that 15% of men have got an additional feeder vein that comes below it. And if you tie off the spermatic vein and they're on the table, the moment they get off the table, it goes through the other vein. They've got the varicocele back again. Whereas if you do interventional radiology, they can see the feeder vein, they can ablate that or block that as well. So I advise my male patients to do that. And I tell male patients who've got low sperm counts that it's not common for varicocele to cause low sperm counts. The typical man with a varicocele has got a high sperm count, low motility, and poor morphology. We call that a stress reaction or stress pattern. Men who've got high FSH levels do not respond to varicocelectomies or varicocele ablation. So I have a long chat with them. Some of them will benefit, and it's worth considering. The other thing you can do is a test known as the sperm chromatin structure assay, or also to have a look and see whether the DNA structure of the sperm is normal. I don't think that it really is an indication not to do IVF. And I know that sometimes varicoceles also produce abnormalities in the sperm chromatin structure assay. And if you do the varicocele surgery, it will return. But I've noticed that a lot of men that go on to Proceptin, their sperm chromatin structure assay returns to normal.
Wow.
The fragmentation index improves. You'll hear them tell you that the DFI or the DNA fragmentation index needs to be under 15%. That's, of course, optimal and that's Superman. But under 30 is pretty good as far as I'm concerned. But that, even if it's 70%, it doesn't mean that all the sperm are abnormal. 30% is still normal. So you can still go ahead and selectively do ICSI and get a good result. So doing a DFI may be helpful to some men and direct you where you should go. Mm-hmm. If a man has got a very high FSH and LH level, it often means that the testes are unable to produce sperm adequately. You can go in and take sperm directly out of the testicles by doing testicular sperm extraction or testicular sperm aspiration, and you can get some sperm that can be used. Even some men who produce absolutely no sperm due to high FSH and testicular failure will sometimes benefit from that procedure. Men who've had a vasectomy, obviously they won't have any sperm in the testicles. The giveaway is their FSH level in their blood is normal, usually under 7. And those men need to do testicular sperm extractions as well, which is very, very helpful. There are some conditions where you can do nothing, and then you need donor sperm. And these are men where there's no production. A biopsy on the testicle will reveal spermatogenesis is not taking place. There are certain genetic abnormalities that preclude sperm production, where you also have to use donor sperm. There are certain genetic problems where you can still find embryos that will be normal, even if the sperm is genetically abnormal. One is Klinefelter syndrome. You can test the embryo and do genetic testing to see which one is okay. It's a long shot. Most of them need sperm donors as well.
So the one thing I recommend to all my patients in a heterosexual relationship is to have the male partner ejaculate every other day, starting 30 days before the egg retrieval. There's this misconception that the guy has to save up for the egg retrieval day, and that's actually a myth. So frequent ejaculation decreases sperm DNA fragmentation. And if you want your marriage to stay intact, make sure your wife also orgasms.
Good advice. And by the way, you and I are in 100% agreement.
Yeah.
There's no point in trying to bank as much sperm in the testicles as you can. Means nothing. The sperm is formed 3 months earlier. You may basically get less sperm, but the sperm will be of the same quality or better quality as you've suggested.
Yeah.
But I can't emphasize enough from everything we talk about today. Basics are basics. We can do everything in our power to improve diet, environment, avoid pollutants, do proper evaluation of both partners to see where the problem lies. But in most cases, it is the egg that is the issue. You can do a lot for the sperm. Most of it is dealt with through selecting the sperm properly and doing ICSI. And if you do that, you can get away with most. Your focus, unfortunately, needs to be more upon how to protect the eggs during the developmental process, during the cycle of stimulation. You can't make better eggs unless you're right with the PRP. You can make the eggs better. Using things like growth hormone may improve mitochondrial activity in the egg, and I use it liberally in all my patients I stimulate, starting at the moment about a week or so or two before the cycle begins. I give them human growth hormone. I think it's very helpful and it doesn't do any harm for the short-term use. So I use growth hormone in combination with stimulation, but it is the protocol used for ovarian stimulation. Older women, in my opinion, do not benefit from mini IVFs.
Oh, I'm with you. No, I'm with
Mini
you.
IVF is a fallacy. More harm is done by doctors saying do regular natural cycles or mini low dose stimulation. Do not overstress the ovaries. That is bogus.
Yeah.
The truth of the matter is that if you are already in the category of an age related poor egg quality, the things that diminish that quality is the high LH testosterone environment and the diminished ovarian reserve. By giving a lower dose, you make both those worse because you do nothing to keep the LH in control. And so you make it worse for the woman. They go on thinking they're doing the right thing, having eggs retrieved over and over in natural or low stimulation cycles. And then to make matters worse, the doctor gives the patient Clomid or letrozole, which boosts the LH even more.
Right.
And in my opinion, those are all the wrong things to do.
Yeah, I say less is more when you have less eggs, but less isn't more when you have more eggs. More is always more.
More is always more and better.
Always more. There's no such thing as having too many eggs and having that be a bad thing.
If you've got a problem, as you've just illustrated by your own experience with PRP, if you can get 12 follicles to make 10 eggs, and even if out of those 10 eggs, only one is going to be normal, you have a better chance of getting that one if you get 10 than if you get 3.
Exactly.
And I often will tell my patients to have repeated cycles of retrieval and bank the chromosomally normal embryos and store them for subsequent dispensation and draw from that. But the important point is to use a judicious and individualized protocol aimed at avoiding overexposure to LH-induced testosterone. Another bad mistake, I think, in my opinion, people make is overdousing their patients with HCG, because that, like LH, is only going to make more testosterone get formed in the ovary, especially if the woman has got diminished reserve. So I don't use HCG supplementation during stimulation, and I don't use testosterone supplementation that some people get given. I think that's a major mistake. And I try to use the birth control pill to keep the LH at bay, overlap with Lupron to get follicles, to form antral follicles, and keep the LH low, and then supplement back with some Menopur to give a little bit of LH when they go onto the antagonist cycle. And using that, you get far better egg quality, you get more eggs, you get better results. And I use a lot of that because my practice is 70 or 80% women who've got diminished reserve or have failed repeatedly because of poor egg quality. And I'm sure yours is too.
Yes. Yeah.
It gets more and more as people get to know who you are and what you stand for. And I often tell my patients, and this is something I want to say, I do what I do because it's my passion. And I want to help people. If I can't help, I want to be out of the way. So I really and truly do not try to attract patients to do IVF under every circumstance or try to entice them by soliciting them. It's not on my agenda at all. I do what I do because I love what I do and I can't do without it. I've been doing it for 36 years and I can't just fold. My wife doesn't want me at home all the time anyway. So I do what I do because it's my passion. And if I can help, it's what I like to do.
Yeah, I mean, I think your passion comes across, your wisdom. I have so many patients who, share with me how much they've learned from all the recordings that we've done over the years. So thank you for still working so
Thank
hard,
you.
even though you don't need to. So, what are some of the emerging technologies or research areas focused on improving egg quality and IVF outcomes that you know of that you can share with us?
We developed a test called HLA-G, which is human leukocyte antigen G, which we measured in the fluid around the embryo, which didn't take off. It was very complex and people didn't want to do it, but it works. If the HLA-G level in the fluid around the embryo in the petri dish is normal, the embryo is more likely to be competent to make a baby. So HLA-G can be used. There are newer tests that are being used doing video screening of the embryo's development. I'm not a big fan. I know it's being used widely. I'm not a believer, but I'm willing to be convinced if someone can show me. We are doing some of that as well. The most important is the embryo's chromosomal integrity. Embryos that don't make blastocysts are aneuploid. You're not going to get a baby from an embryo that never reached blastocyst by at the latest 6 days after fertilization. Embryos that take 7 days, even if they're normal, there's some chromosomally, there's something else, they usually don't make babies. It's embryos that reach blastocyst within 5 or 6 days that you really want to consider for PGT. And those are the ones we biopsy, which is why I don't see the common sense any longer, unless the woman insists upon it, unless she's having a one-shot go and she's older, to put back embryos on day 3. Obviously, if the embryo you put back in day 3 is normal, and you won't know it unless it goes on to be normal, she'll have a baby as easily if you do PGT.
Yeah.
But if you're going to bank embryos, and if you're going to put back embryos as a general rule, you're far better off doing PGT on the blastocysts, freezing the embryos, and coming back and doing frozen transfers, especially in this day where the techniques we use for freezing are so safe. And so in this day and age, that's my position on it.
Yeah. When it comes to day 3 freezing, I do offer that to patients, but the way I offer it is in this way. I say to them, this is such a spiritual journey, which is having a baby. And if you will feel like you lost something, then it's important to honor that and freeze day 3. Because if on day 5 I call you and I say there's no blast, then I don't want you to feel like you wish you had made a different decision. And women who are just starting IVF, sometimes they haven't had the experience that you and I have had and our other patients have had. And they will see missing out on having a day 5 blast as a tremendous loss. They will get very depressed.
Major disappointment. I applaud you for that. I totally applaud that.
Yeah.
But I think it's a good idea because there's another reason it's a good idea. If you freeze an embryo as a blastocyst and you've not done PGT, you can still rethaw it, retest it, and then transfer it, but at a price. Because even though babies do happen from embryos secondarily tested, you're taking an embryo that was frozen, you're thawing it, putting it through biopsy surgery, refreezing it to rethaw it. The embryo is really pummeled and it doesn't have as good a chance as ending up being a baby.
Right.
So my position is that's not optimal. If you're going to freeze blastocysts, biopsy them first, and then they do good. But if you freeze a day 3 embryo, you can always thaw it, allow it to go to blastocysts and still test it without prejudice. Whereas you have a prejudice if you try to do that with frozen blastocysts that were untested, because they can recover from day 3 to day 5 or 6 quite easily and readily.
Right. So the question I ask my patient is your priority to have an embryo transfer, or is your priority to transfer an embryo that you know is competent? And then they get to choose.
And you're right.
Yeah.
The patient is always right.
Yeah. For some patients, they just want the experience of having an embryo transfer. They understand what the worst case scenarios are. I talk to them because of their age. If they have a miscarriage, you can take them out of being able to do more cycles as long as they all know that that I'm fine doing it. But I feel like there are these myths out there like day 3 is better than day 5 for older women. And I say it's actually, I don't think it is. It is not better, but I think it might be better for you emotionally because you'll have something to transfer. But then it could also give you false hope because if you're transferring a gorgeous 8-cell grade 1, you're going to, no matter what I say to you, you might beat yourself up and think you did something wrong. But in the end, it's because the embryo was not genetically normal.
And if that embryo was normal, unbeknownst to you, it's just as likely to make a baby as if you took it to blastocyst. Taking it to blastocyst isn't something magical. If you knew which embryo is normal as a pronucleate on day 2, you could still put it back and would have the same chance of making a baby. So I applaud that because it's always the patient's choice. Our job isn't to tell people what to do. Our job is to give people information so they can decide what to do.
Exactly. So is there anything else you'd like to add today about embryo quality?
I can't think. If you've got anything in your mind you'd
No,
like to throw at
no,
me,
no.
but I do want to say this to you because you deserve it. You do a wonderful job. I think you're an outstanding person. I think you're a wonderful doctor, and anybody who has you as a doctor is very fortunate because you give so much. And it's always a privilege and a pleasure to be with you and talk to you and exchange ideas and learn from you too.
Same, same. I always learn from you, always. Like, what did you say? Your your egg quality is only zona deep. That's very cute. So where can people find you and how can they work with you?
Well, again, if you want to send me anybody, they go back to you, as you know. I'm not there to try to capture patients from other doctors. I don't need to. But I do need to have a full consultation with everyone as if they'd not been through it before, so I can dig into it and see if there's anything that I can bring out that might be beneficial to them. The only requirement is that I do a full consultation on anybody I speak to, that they don't just phone me up and say, look, tell me this, tell me that. I just don't have the time or the inclination to do a half-baked job. So if they want to reach me, they can email my assistant, Patty. She's marvelous. You call Patty Converse and reach her by going to concierge, CONCIERGE, at Sher, SHER, IVF.com, or call her directly at 702 533 2691. And Patty will always respond. If you want to do a consultation with me, she'll set you up, send you a questionnaire to complete, try to get as many records as is possible, and then we'll sit down and have a discussion, always coming from the standpoint that I'm only there to give you information so you and your significant other, male or female, can make the decision as to what you want to do. And if then we come into the picture, we're available. If it's with your own doctor, I have no problem talking to your doctor. If he or she reaches out to me and talks to me, it doesn't cost you anything. Oftentimes that's not as easy, but I would be willing to be of help in any way that I can.
Tell us about other books that you've published and where patients can find them.
The most recent one I wrote was In Vitro Fertilization, The Art of Making Babies, which came out and was very widely read, but it was written about 7-8 years ago, so it's really not available, which is why Dr. Tortriello and I got together and wrote this book, which will be out soon. I've also got another book available on the immunology of infertility and recurrent pregnancy loss, also available as a downloadable free ebook, but it is available presently for anybody who wants it. All they have to do is contact my assistant, Patty, and she'll send you a link to the book and you'll have access to it. Again, concierge at sharevf.com.
Great. And we'll include Patty's information in the show notes for anyone who's listening who wants to reach out to Patty. And we love Patty over here. She's so kind and helpful. So I'm so glad that you're giving her information out. Well, thank you again, Jeff. Thank you for joining me today. You're awesome. Your podcast recordings always have the highest downloads. So the information that you share is invaluable. So thank you so much. Thank you for your time.
You're the sweetest thing. Thank you so much. Have a wonderful evening.
Thank you.
Bye.